Good afternoon, ladies and gentlemen. I am Dr. Asif Zaman Tushar, Associate Consultant, Evercare Hospital. The topic is sudden cardiac death in HCM, a silent assassin. So, hypertrophic cardiomyopathy is one of the most common inheritable cardiomyopathies that we have, with a prevalence of 1 in 500. HCM is characterized by myocardial disarray, fibrosis, and small vessel disease.
And beside
Macroscopically, the hypertrophy is typically
respiratory input
25% of patients have resting left ventricular outflow tract obstruction. Sudden cardiac death is the most common cause of death in HCM and often affects the young and frequently asymptomatic patients, though the annual sudden cardiac death rate is less than 1%. In infants and children, HCM is often associated with syndromes such as Noonan syndrome, Lippert syndrome, and metabolic disease such as glycogen storage disease. And in adults and adolescents, the HCM is primarily caused by mutation in cardiac sarcomeric protein genes and is inherited as an autosomal dominant manner. Sudden cardiac death in HCM is mediated primarily by ventricular fibrillation. In addition to ventricular fibrillation, asystole and pulseless electrical activity have both been reported in association with sudden cardiac death. So what is the electrophysiological mechanism of arrhythmia in HCM? Interventricular dispersion of conduction due to variable cardiomyocyte size, fibrosis, and disarray produce the re-entry mediated tachycardia, which is most common in HCM. The disrupted intercalated discs produce disturbed conduction of
and beside me
cardiomyocytes and promote arrhythmias. Increased myofilament calcium sensitivity
and therapeutic dilemma of a wide complex tachycardia.
Dispersion of repolarization
This
capable of generating
talk is
functional re-entry. So for all these patients, what we want to do for heart rate rhythm assessment, the recommendations are: in patients with HCM, 12-lead ECG is recommended in the initial evaluation and as part of periodic follow-up every 1 or 2 years. And in patients with HCM, 24 to 48 hours ambulatory electrocardiographic monitoring is recommended in the initial evaluation and as part of periodic follow-up to identify patients who are at risk for sudden cardiac death, not all, and guide management of arrhythmias. Now comes the sudden cardiac death risk assessment. In patients with HCM, a comprehensive, systematic, non-invasive SCD risk assessment at initial evaluation and every 1 or 2 years thereafter is recommended and should include evaluation of these risk factors. That is, personal history of sudden cardiac arrest or sustained ventricular arrhythmias, personal history of syncope suspected by clinical history to be arrhythmic, family history in close relative of premature HCM-related sudden death, cardiac arrest, or sustained ventricular arrhythmias, maximal left ventricular wall thickness, ejection fraction, and LV apical aneurysm, and non-sustained ventricular tachycardia episodes on continuous ambulatory electrocardiographic monitoring. For patients with HCM who are not otherwise identified as high risk for sudden cardiac death, or in whom a decision to proceed with implantable cardioverter defibrillator placement remains uncertain after clinical assessment that includes personal or family history, echocardiography, and ambulatory electrocardiographic monitoring, cardiovascular magnetic resonance imaging, or CMR, is beneficial to assess maximal LV wall thickness, ejection fraction, LV apical aneurysm, and the extent of myocardial fibrosis with late gadolinium enhancement. For patients who are more than or equal to 16 years of age with HCM, it is reasonable to obtain echocardiography derived left atrial diameter and maximal left ventricular outflow tract gradient to aid in calculating an estimated 5-year sudden cardiac death risk that may be useful during shared decision making for implantable cardioverter defibrillator placement. So this is the thing that we need: the established clinical risk factor for HCM sudden cardiac risk stratification. Family history of sudden death from HCM. what we should look for. Sudden death judged definitely or likely attributable to HCM in more than one first degree or close relatives who are less than or equal to 50 years of age, and close relatives would generally be second degree relatives. However, multiple sudden cardiac death in tertiary relatives should also be considered relevant. Massive left ventricular hypertrophy, which means the wall thickness more than or equal to 30 millimeter in any segment within the chamber by echocardiography or cardiac magnetic resonance imaging. Consideration for morphological marker is also given to borderline values of more than 28 millimeter individual patients as the discretion of the treating cardiologist. For pediatric patients with HCM, an absolute or Z score threshold for wall thickness not been established. However, maximal wall thickness correspond to the Z score of 20. Unexplained syncope, HCM with LV systolic dysfunction with ejection fraction less than 50%, extensive late gadolinium enhancement on CMR, and non-sustained VT on Holter. Now the selection of the ICD for these patients, that is 2A recommendation. The patient with sudden death just definitely or likely attributable to HCM in more than one first degree or close relatives with less than 50 years of age, massive LVH of more than 30 millimeter, more than one recent episodes of syncope suspected by arrhythmia, suspected of arrhythmic, LV apical aneurysm and LV systolic dysfunction. Sorry for, I couldn't complete the thing. I'm giving the last take-home message, that is, although the risk of sudden cardiac death in HCM is low, great efforts should be made to identify small subset of patients who will experience sudden cardiac death. And the decision to recommend ICD should be based on individual judgment for the particular patient by taking into account the overall clinical profile. Thank you.
Thank you, Dr. Tushar. This is a brilliant presentation.